my name is Jonathan Benjamin, and I am a second-year radiology resident at Einstein Medical Center in Philadelphia, Pennsylvania, and I'll be presenting my case on a thoracic meningocele. Our patient is a 65-year-old woman who presents with mid to lower back pain, numbness, and tingling. Initial PA and lateral chest radiographs show a large, smoothly marginated right perivertebral mass as indicated by the blue circles. Note multiple nodules localized to the skin surface as indicated by the yellow arrows. An axial contrast-enhanced chest CT image shows a simple fluid density right perivertebral mass as indicated by the blue circle, which is arising from and widening the spinal canal, and again note the multiple cutaneous nodules. Coronal and sagittal contrast-enhanced chest CT images show a simple fluid density right perivertebral mass as indicated by the blue circle arising from the spinal canal at the apex of the patient's convex right mid-thoracic spinal curvature. Note dural ectasia as indicated by the yellow circle, with remodeling of the vertebral bodies, as I point out with the white arrow. Next, axial and coronal T2 weighted MR images of the thoracic spine show a right perivertebral, hyperintense, smooth-walled, cystic mass, as indicated by the blue circle arising from the spinal canal at the apex of the spinal curvature. Our diagnosis is a thoracic meningocele in neurofibromatosis type 1. It is a homogeneous, smooth-walled, cystic perivertebral mass, which arises from the spinal canal at the apex of the thoracic spinal curvature, with associated vertebral scalloping and dural ectasia. It is hyperintense on T2 and hypointense on T1 weighted sequences, following CSF signal intensity. Our main differential diagnosis is a foregut duplication cyst. Foregut duplication cysts result from abnormal budding of the foregut during development, resulting in cystic lesions which are hyperintense on T2 weighted sequences with variable T1 weighted signal intensity. Bronchogenic cysts are usually adjacent to the tracheal carina, while esophageal duplication cysts occur in the perivertebral mediastinum and contact the esophagus. Our patient's mass arises from the spinal canal, making a foregut duplication cyst unlikely. The take-home messages for our case are that thoracic meningoceles are rare, with most 60 to 85% occurring with neurofibromatosis type 1. They are usually asymptomatic, but when large can compress adjacent structures, resulting in dyspnea, cough, back pain, or paraparesis. They are smooth perivertebral masses, which are in conjunction with a scoliotic curve, and well circumscribed and cystic on CT and MRI. Small asymptomatic meningoceles can be followed with serial imaging. However, if the patient is symptomatic or if there is rapid growth, surgical management is indicated.